Health Science 312 Project and Group Number 22. Our proposed intervention targets malaria in pregnant women, children under 5 in Asaba, Nigeria. We are the National Health Organization, where our project is called Malaria Be Gone, to target the malaria prevalence and morbidity and mortality rates in Asaba, Nigeria. The rationale for choosing Asaba for our pilot project is that Asaba is a fast-growing urban population which have caused them to be more at risk for malaria than the national Nigerian statistical average. This is alarming as Nigeria already has the highest malaria prevalence and death rate globally. Our objectives and goals are that by the end of the project, malaria cases should decrease by at least 50% and the use of mosquito nets should increase by 80% in our participants. We also want to see an increase in national support, which will lead to a national mosquito net program to be the main intervention used to decrease malaria infections in pregnant women and children under 5. Our target population are pregnant women and children under 5 because pregnant women are especially vulnerable as immunity decreases during pregnancy. In Nigeria, this group accounts for 11% of maternal mortality rates, and children under 5 are especially vulnerable as their immune systems are not fully developed. This is a huge problem in Nigeria, where malaria contributes to 30% of deaths in children under 5 and 25% deaths of infants. Our first activity will be offering mosquito nets at local hospitals and maternity wards and NGO-led outreaches in Asaba. We can use these NGOs to identify local gatekeepers to better reach our target population. Our second activity is to increase awareness in the usage of mosquito nets within our participants. This will be done through educational workshops. Nigeria spent a total of $2.4 billion USD on malaria in 2013. With this program, it will greatly reduce the cost spent on malaria and have other benefits like increased productivity, which will boost the economy. We can assume that implementing mosquito nets in Asaba will have the same effect. We also expect further funding from Nigeria's National Malaria Control Program once our intervention is proven to be effective. To evaluate our intervention, we will randomly select 200 households in Asaba as our control group. Our experimental group will be another 200 households that undergo educational workshops and are distributed mosquito nets. At the end of our 1-year program, we will follow up with our participating 200 households to record their malaria prevalence and mortality and morbidity rates and their usage of mosquito nets. We can then compare it to the other 200 households that weren't enrolled in our study. Our finances requested are from WHO, National Malaria Control Program, Every Mother Counts, CIF Canada, and Against Malaria Foundation. Our total program cost for 1 year is $86,450.